Can you hear
Good
me?
morning. Yeah, good morning, Dr. Goel. Ramesh Dagubati here. How are you
Yeah,
doing?
yeah, good. Thank you. Nice
Yeah,
to hear from
Doctor,
you. And at the outset, I must thank Dr. Srinivas for having given us the opportunity.
yes, thank
Okay.
you. And with me is
Uh,
Dr. Pratap Kumar, Dr. K. Parikh, Dr. Lekha Pathak, and Dr. Sunil Modi.
okay, great. So this time I'm going to show, because this is imaging guided PCI left main. So I have taken a case of left main with imaging possibility. So I'll have you, Dr. Vaibhav, who's going to tell you the case details. Dr. Vaibhav, please.
yeah, today we have 61-year female who is diabetic hypertensive. She had a patient of old inferior volamine in 2022. She is post PTCA to RCA for inferior volamine in 2022 outside, and she has the residual class 1 to 2 angina and rest pain occasionally. Coronary angiogram showed residual distal LM plus minus LED osteal 80 to 90% tubular lesion with heavy calcium, and she has been advised for PTCA to stent to LED osteal with IVL. And her ECG is
RBP.
RBB sinus rhythm.
We don't see much Q waves, whatever it is. So she had an inferior MI, and after the
Go to the next slide.
you've seen the slide.
Yes.
Yeah. So basically it had left main disease and osteal LAD disease, which was left at that stage, and she
Only
took time
ECG is
to
there. ECG. Dr. Goel, can you just go to the next slide and show the
the angiogram. I'll show you the angiogram.
no,
Yes.
PowerPoint. Okay.
Okay. So this was the this is the right we checked was normal. I'll show you that right also. So this is the left angio eleocranial view, as you see, and in this you see the proximal and osteal LAD looks diseased and irregular. The circumflex looks okay relatively. Next. No. That's a go back. That's fine. That's perfect. That's a spider view which shows the osteal LAD disease, which is at least 85%, I would say. And the circumflex ostium also has some disease. We'll see it better in some other views. Next. Now, this is the cranial view, which shows that the distal left main probably has lesion, which was not seen in the other view. And we have a little longish LAD lesion from the ostium to the proximal LAD. Go ahead, please. Next. Go back, please. Show the right. First angio. Okay. And that was the first angio which we checked the right. So right looks okay. Next. That's the RO view. So with that disease, I think the first thing was to do imaging and see how the confirm the disease is restricted to LAD or there is left main, and how much is the disease, how much is the calcium. So I've done a OCT. I'll show you the OCT. Can we see that OCT run, please? Can we see the OCT run? Can we see the OCT run? It is not. Okay. So can you see the OCT run? This is this the main run, second run. Can you see it? So you see initially we showed you the distal vessel, which was normal, and then there are areas of almost 360-degree calcium, and then as we are coming back towards the proximal vessel, there's more disease. This is near the ostium. You see, that's the ostium of the LAD, and the caliber there is about 2.34 millimeters square. And then we have the that's the circumflex coming up. There's a second wire from the circumflex, and it is only in the distal most part there is some left main disease, but yes, it is there. That's what I feel. I wonder if you have any thoughts on it. So that is it. So that's the osteal LAD. Move towards the left main. Move towards yeah, not so fast. Move it a little slow, please. Move it a little slow, please. From osteal LAD towards
reverse slow.
Yeah.
Okay.
Frame by frame. 1, 2, frame by frame, sir. Just frame by frame. Go back to the osteal LAD and show it move by frame. One frame. So that is the osteal LAD. trying to get towards the circumflex and left main. Next frame. Next frame. That's circumflex coming up. Next frame. Next frame. That's the wire in the circumflex telling us now we are in the left main. So this left main is diseased. Next frame. The second wire is coming up. Next frame. So this is the distal left main. So, and it has calcium all around, as you see.
What's the lumen area in LMCA? That part?
Can you measure this lumen area?
No, it is written
But this
above.
is
3.47.
3.47 it says. That's fine. It says 3.47. Okay. Move forward towards left main. More towards left main. Yes, stop it there. So we have calcium in left main, and the area here is about 4.2. So, you know, less than 4.5 for left main is significant. Less than 2.5 for LAD is significant. So we have significant disease in the left main LAD, and it is all calcific, and we have areas of 180 to 360 degrees calcium scattered all around. So my strategy, I wonder what would be the thoughts you would do. Well,
Will you do an OCT run from circumflex to LAD, LMCA?
well, I am not very keen to do that, you know, because we've seen the circumflex mouth has some stenosis. We understand that. If you want, I can do that from the circumflex.
Ideally,
also.
in every setting, you know, every image setting, actually.
Yeah, let us do the
even if you see
circumflex.
that nothing is there, you have to do one more run from the
Okay, I'll do it right now.
makes your life easier.
Okay, I'll just do it right away.
Yeah,
Okay.
I mean, I think estimating the osteal circumflex from an
Yeah, that is
angle
important. I
is
understand
not very good,
deciding the strategy for the left main.
Yeah.
Because on the angiogram, I thought it is about 60%, and I could not, I might not leave it just like that. I might do only a boost and
Even
strategy.
in the OCT run from the LAD to LMCA, you
Yeah,
can
it looked
the
open, huh?
costume is good. But even then, the ideal way, when you plan, you do an imaging, you should have imaging from both the sides. That will be ideal for it.
Yeah.
Planning strategy. In this case, by without imaging, our plan will be a single stent strategy from LMCA to LAD, and from which part of LMCA to LAD is the question mark, whether will you take up to the ostium or from the mid part, because it's a long LMCA.
Branches, identify the vessels.
Dr. Lekha Pathak, do you think?
Okay, so I am doing it now, right now. Just do a purge, please.
What do you think about the EBC main results, Dr. Pathak?
Okay, I am ready.
EBC main, the left main. Dr. Sunil Modi, what do you think about EBC main results?
Some echo. I'm
EBC
not able to hear you.
main. EBC.
So that is it.
EBC main. Okay. Okay.
So
Yeah,
can we
sure.
see?
Yes, shown on OCT that.
Yeah, you can show the OCT. After that, we can talk. Yeah.
Yeah. Can we see the OCT now?
Oh, there is definitely disease at the circumflex ostium.
Yeah, I could, let us see.
How much is the disease?
Okay,
To see?
let us see. Run it, please. Go back. Yeah.
Looks okay. Looks okay.
Looks okay here. Go ahead. Move forward.
Come
Move
back.
forward.
Come back to the
No, we have
proximal
not
part.
entered the left main.
No,
Move
come
forward.
back to the proximal part. Come.
Come back. Keep continuing to come back. Come back. Come back. Come back.
OCT guy
Come
is a
back.
very slow guy.
Come back.
Not copying up
Come
with
back.
the face of Dr. Goel.
Yeah, so that's the ostium of the circumflex. You see that? So
Yes.
it has narrowing there. And I think the area, what it is, say the area there. It says 3.5. Okay. Keep moving. Keep moving towards, it's still tighter there. Keep moving towards the circumflex, towards the left main.
It's
Keep
tight.
moving, please. Keep moving, please. And
Ostium.
that's the left main. That's the distal part which had disease. So it's a true bifurcation actually.
No, we want to see the ostial circ only. Just can
Yeah,
you do this
ostial circ I
distal-
showed you, na?
Distal. Can you go distally and show the ostial
Just
circ?
go a little distal. towards the circumflex, frame by frame. Keep moving, keep moving. So that is circumflex.
Yeah.
That is circumflex.
So
Okay.
it is disease, no doubt, but it is still very focal lesion.
Yeah, it is focal.
I
Yes.
still
So
think
now,
positional stent with the kissing balloon or drug-eluting balloon to the side branch is more than enough here. That's my opinion.
now this is what will depend how I think about it. I am not a very strong proponent for crossovers. Sometimes you pinch these circumflexes and then there's a problem to re-enter. At least for the left main bifurcation, if there is disease, I would prefer 2 stents.
Actually,
And it is calcific. You see, there's so much of calcium there.
by definition, it is less than 10 millimeters, 10 millimeters.
Yes,
and
I
also
understand. It
it's
is
a very
low
focal.
risk.
You can just go with a single stent.
Yes, you are.
Right.
That is the EBC. That's what EBC says.
So Dr.
But
Goel,
the
so you're
issue
planning
is-
to go with the
I am planning to do a IVL to the left main to LAD and for the calcium. And then depending on the result, what happens, we can have 1 or 2 stent strategy. I probably might end up in 2 stents. To be very frank, this is what.
So please do whatever you feel like. We'll come back to you after.
Okay.
Actually,
You come back to me
Goel,
after
if you do
15
an
minutes.
IVL to LMCA to LAD, then you can use the same IVL balloon for the circosteum also. If you have
Yes.
a plan for doing
Provided it
different
goes in there. Provided it goes in there. Because IVL balloons are very bulky. And once
in that
inflated, they
situation,
don't
you should
move.
take the IVL balloon first to the circumflex than to the LAD.
Let us see. I think I'll do the LAD because that's more important vessel and circumflex is more discreet.
Yeah. Dr. Goel is very
yeah.
experienced. We'll see whatever you have done. I'm sure it'll be perfect. We'll come back to you in a few minutes. Dr. Goel, we're back with you, sir.
Yeah, I think we'll do 28. Okay. So you see, I'll show you what I have done. Can I go back to the previous angios from where we left them?
एंजियो लगाओ जो balloon कर रहे हैं ऊपर
नहीं आगे after the OCT, yeah, somewhere here. Start. Okay. So this is where we were. Move forward. So this was the. Keep moving. Move forward. I did a 2.5 balloon to create some tract for the IVL to go, and this was the OCT that we did. And we see that the circumflex lesion looks significant already here. Next. So this was the IVL. This was a 4-0 IVL. And you see how it slips out. Move. And
You could easily take a IVL balloon without any pre-dilatation.
Yes.
Okay.
You see, it slips out. That tells me, when balloons slip out, when you do full inflation at one go, they slip out if the lesion is not responding. And this is only at 4 atmospheres and it is slipping out. So then what I did was slow inflation 2. And so now I am sitting here more in the left main, little in the ostium into the LAD. And you see that is not inflated. And this is where the energy is going. And if you will see at the end, I don't know whether you'll observe that, it becomes bigger.
There was a BP fall during that time?
Yes, there was some BP fall during
Definitely, that time
yes,
the heart movement was very less.
Next, please.
Now
Next, please. Let us see. Now this is a little distal with the same 4-0 because we're using low pressures. So when I do left main to LAD, I am okay with 4-0 IVL. I need not be very conservative and use 3.5. Maybe the LAD here is only 3.5. So, and then, at the end, it becomes bigger. We started with a smaller size, means caliber as on the angio, and then at the end it becomes bigger, means it's breaking the calcium and it's getting you away. Next, and after that, after this thing, you have small dissection there at the left main distal end at the proximal LAD, and the circumflex doesn't look good to me at all. So I decided that I'll do 2 stent strategy here, and so I put a stent. 3, this is the stent, I think. No, this is the balloon.
Now, did you do a pre-dilatation of IVL to the circumflex?
Yes, this is that balloon pre-dilatation to the circumflex. Next.
No, balloon or IVL?
No, I did not do IVL there.
Okay.
I did not do IVL there. Because, it is discrete. The circumflex lesion is discrete. We all agree that. And with discrete and, I have already handled the left main calcium through IVL. So it will break on the circumflex side also. I wasn't very, this thing. Otherwise, I would have had to use one more balloon. And for the circumflex, I would not have used more than 3.5, certainly. And there I had a 4. So I did not want to open that. So I did only balloon. And so that's the result with the balloon or stent. That's balloon. Next. So I told you I have decided 2-stent strategy. So that's the stent. This is a 312 in the Zions in the circumflex ostium. Now the Zion stent starts from the dot. So what I'm trying to do, majority of these cases, I do not have big areas overlapping inside the left main. I try to, now this angle is about 60 degrees, I would say. You would agree, this is about 60 degrees. If it were 65, 70, this would be the best strategy. I'll just keep it more like a T stent. So anyhow, it is a little into the left main and I have done the stent. Go ahead. Move forward, please. So that is how this, next, these are test shots and that's the stent expanded. So that's the result post stent. And then we did compression from the side balloon. This is crushed with a 30 balloon there to have a track. And then I did some balloon dilatation distally next in the LAD. And now I want to do stent of the LAD. So, and then finally we have to do a kissing balloon, pot and a kissing balloon. So the stent now, the distal LAD, as I measured, is only about 3.3 or something. So, and the left main is certainly 4 or 4.2. With this, one strategy sometimes that I do is have a 3.5 and expand it to 4 in the left main. Yeah. But here it is a little longer and 3.5 for that distal LAD, that segment of the LAD may not be good.
You can take a 3.5 48 stent and finish it off.
I am not sure whether 3.5 will accept
3 or 48 and then proximal part you can dilate up to 4. 5. 4.
Yeah.
Well, my thought is that I will do which one? 328 or something distally, and then do the remaining gap with a 412 or 415.
Sure.
Yeah. So let's further. So 328 Zines, please.
So you're going with the nano stent strategy almost, right? Or, nano crush.
Yeah. Whatever you call.
It is not nano crush.
Yeah, this is nano crush. Yes. I do this nano crush. I agree on that. And I'll tell you one more thing. I wanted to show you that. But because my case turned out to be with some left main disease, if I can see a slide, I do very often pure osteal stent. Can I have a slide, please? The next slide. This is a little away from, just understand this. If the left main, I hope you're seeing this slide.
Yes.
If the left main would not have had the lesion, and I had true osteal, as I showed you on the spider, it looked osteal only, but we know that this patient had left main distal and some disease. You see, this is AP caudal view, RAO caudal view, LAO caudal view. The stent position is same. And there are 2 wires. I call it the 2-wire technique. In fact, I have given it for publication. It is not yet published, but I call it a 2-wire technique, but I would like to have you understand this. It's very useful to place a true osteal stent. Now, in the first one, if you see the AP caudal view, that's the usual view we take that to see, we are almost in the near the ostium of the vessel. What happens with osteal stenting is either you miss it or you overdo on it. Either you miss the ostium and you are distal, or you overdo and you are in the left main and then you mess up the circumflex. So here it looks in AP caudal first view, it looks almost you are there. The same thing in RAO caudal, if you see, you are far away. This is basically because angiographically this segment gets foreshortened, and you believe in spider views. Everyone believes in spider views. The same position on the spider view will look like this. You will feel as if you are already inside the circumflex. But truly, the RAO caudal, when it is showing you the circumflex is away and you are in the your stent has a good gap, You are not away. So in the areocaudal view, you bring it back to the circumflex ostium, and the two wires tell you the first. Go to the next slide, please. This tells you A and B. A is the gap that the stent will expand. You imagine in your mind when it expands how much it will become. And from that edge, you should leave a distance from the circumflex wire, which is the true gap of the circumflex. And then you will be true in the ostium. Well, in this case, I can't do that, but I thought that I might do it. So
Basically, it looks like a very complicated that the Japanese give a talk, you know.
Yes, yes.
So actually, you have to come and give a talk.
You will see it published. You will see it published.
Yeah. We will be seeing the case.
So,
can you just go because another 4 minutes
I'm
only,
sorry.
4
Yeah,
minutes.
I'm just. This is which wire? LED.
LED.
328. Okay. So I am going to the LED 328.
So yeah, we published actually a paper, crossover stenting for ostial LAD versus precise stent placement. Crossover is definitely better.
Okay. All right. But well, I have done these cases and the results are good. I have written in that there are no coming backs or restenosis. But that's once it gets published, then we'll know that. Test, please. Am I too far? Wait a second. Angio, please.
So Dr. Goel, don't rush. Even if we will come back to you. Okay?
Yeah, that's fine. That's what I was thinking. Is
Ramesh, Ramesh,
yes,
don't you
Sunil.
think this was a clear-cut case for two stent and mini crush?
So, I mean, in my practice, I would deal with as a simple bifurcation lesion as defined by the definition study and would do provisional stent and either prep the side branch with either balloon or a cutting balloon and leave it alone, okay, with after final kissing balloon. In India, actually, you have at least a drug-eluting balloon, and this is what actually most
No,
of
if you are doing two stent, then
I would go for the TK crush.
Well, I don't know if you ask people to raise their hands in the audience, how many would want a crossover stent in this, and how many would want a two stent?
How many?
Can we have a voting?
Provisional stent.
Provisional
Audience, raise your hands.
How many 2-stent strategies?
2 stent strategies. Okay, provisional stent wins by about maybe
70 to 30%. He will
70
tell
to 30.
90, 10,
But
no,
out of those
70,
70, I tell you, this is on the lighter side. 40 might be theoreticians. You know, you see, practice is stronger than.
So you got equal percentage, 30, 40 practitioners. Very good.
Okay, so Dr. Goel will come back to you and we'll listen to this fantastic man next to me, Dr. Pratap Kumar, who is the NIC chair present on his data from NIC registry.
Now give me a 40. 40 3.5 or 4 बनाऊंगा.
4 करें. 4 हो जाएगा.
412, हाँ?
हाँ, 412.
Okay.
या 15.
नहीं 15 नहीं. ये हाथ वहीं रखिए.
आरे कॉर्नर देखता.
1 minute. Just hold on, huh? Come on. The section है. 412. Come on.
412 gents फटाफट.
Come on. लाओ.
जब वोटिंग बार आती तो थ्योरी को चुनता है आदमी पहले. लैब में अलग चुनने वाला. प्रोविजनल असल में ईबीसी बहुत प्रोविजनल वर्ल्ड वाइड प्रोविजनल बहुत सपोर्ट करता है, लेकिन यहाँ तो टू चाहिए. साथ साथ देख रहे हैं. हाँ अभी ठीक हो जाएगा, परेशान ना होइए.
फिक्स. इसमें प्रेशर ज्यादा नहीं देना है मेरे को.
हाँ क्योंकि एकदम डिप पे कर गया. पोस्ट कर लेंगे बाद में, वो अलग बात है. कैल्शियम भी रहेगा यहाँ पर.
To research studies and to learn more about the disease. Patients can.
Hold on.
रुक जाओ.
And ओवरलैप है.
बाहर है, मैं सो रहा हूँ.
ठीक है, चलो अच्छा है. Angio, please come on. I think this is okay. लाओ दो.
जस्ट टचिंग हो गया.
देख लेंगे, कम ऑन ड्रिबल स्टॉप, देख लेंगे, रुके रहो। नहीं ठीक है, नहीं नहीं नहीं, वो वाला ओवरलैप है।
ठीक है, ये प्रॉक्सिमल की कर पॉट कैसे करेंगे? ठीक है, एलसीएस के स्टैंड पर है हम। बस बस
हाँ
बस
हो
बस।
रहा बस।
ये लीजिए।
कम ऑन, या
ठीक
लुक
है,
गुड।
बढ़िया।
चलाओ,
रिक्रॉस करें।
फ्रीज करो
नहीं,
ऊपर, ठीक
पीछे
है।
क्या है? एलएम पर छोटा है क्या?
नहीं नहीं, चलाओ चलाओ,
जस्ट वहीं पर है,
बस
ब्लैक है।
वहीं पर है। हाँ,
ब्लैक है।
नहीं प्लान नहीं है, लाइक 40 का बोलो,
402।
because we are doing it like a T ना।
हमें लगा लेंथ थोड़ी स्टैंड की जाना। चलो ठीक।
चलो,
वो तो 4 4 8 का है। 4 6 है अगर तो।
4 6 का एनसी दे दो,
4 6 एनसी दो।
6 8 दे दो।
4 6।
लाओ। फिक्स। 15 करना चाहिए था।
वही मैं कह रहा हूँ ना, थोड़ा सा अगर प्लाट में है तो हमको लगाना पड़ेगा।
प्लाट ही नहीं है।
हाँ चल। ओके।
1 मिनट,
क्लियर एक्सटेंट।
देखो,
करें।
रुक जाओ, ठीक है, प्लाट में नहीं है, 1 सेकेंड, करो।
गोइंग अप।
10 12 14
14।
डाउन।
एक एनवाई वायर दो। एक पावर टर्न दे दो। ब्लैक। एक गेट का बलून तैयार रखना।
एंजो करोगे,
ये पकड़ो पकड़ो, कब तो गया वो।
कम ऑन, इंजेक्ट।
ठीक है, बोला हमें बस
चलो,
वही देखना प्रॉक्सिमल एज उसका।
नहीं नहीं सही है।
ला वो वायर दो बेटा
नहीं,
भाई। हाँ जल्दी दो, रिक्रॉस करना है ना।
ये वायर आइडेंटिफाई करो।
हाँ मैं करता। ये दो इंट्रोड्यूस। ये पकड़ लिया। ये तो 3.5 और 3 से हो गए।
हाँ, क्या
है
कह
यहीं
रहे हैं
पर
आप?
है, कहीं नहीं गए हैं। हाँ। एक टॉर्कर दीजिए फटाफट।
1.5 का बैलून चाहे मेरे यहाँ
हाँ
से ले आओ।
1.5 दो तो लाके रखे हो गए।
और कर दो।
हाँ ये लीजिए। हाँ इधर आप पहले क्रॉप लगाना। ये क्या है, आईवीएल है? इसको उधर रख दो, इसकी जरूरत अब नहीं है आईवीएल की। हटो देन, थोड़ा उधर साइड में जगह बने ना यहाँ पर। इसकी गन गन खोल दें इसकी।
जरा इसको
16। हाँ उठा के, मतलब जगह यहाँ थोड़ी कम हो, भीड़ बहुत हो। आ गया, बहुत हो गया। लाइए 1.5।
इसकी फ्लोरो रिकॉर्डिंग कर लो।
फ्लोरो रिकॉर्ड, फ्लोरो रिकॉर्ड। अरे हो गया था ना। रुके रुके रुके, एक मिनट एक मिनट। बाहर करना हो रहा है। ये लो
1.5 बलून
3.5 एनसी लिया हमने अभी। 3 का लिया था, एक 3.5
लो
फाइनल किसिंग के लिए। ये लो
1.5
1.5 कनेक्टेड, नेगेटिव।
फिक्स।
अब तो आएंगे नहीं, ब्लू आएंगे अभी कम बैक।
पता नहीं।
आई डाउट। 10:30 तक था।
कौन खुलाओ?
और पीछे और
नहीं ठीक है, खुल जाएगा, आ जाएगा। डाउन।
अब दीजिए 3 वाला एनसी और उधर 3.5 वाला एनसी।
पहले 3 वाला दो।
हाँ वही कर लो, मान लो 3 करेंगे पहले। 3 दीजिए, 3 का एनसी। आराम आराम से, मेरे लग जाएगा कर दो। पकड़ा हुआ है पर।
फिक्स।
टेक्स्ट। क्रॉस्ड।
लाओ एक 3.5 का लाओ।
लो 3.5। नहीं सही होगा।
लास्ट में को सिटी रन करेंगे। फिक्स।
एलईडी की तरफ कर लेंगे एक मिनट। गया गाइड। एलईडी
करिए 12।
12।
डाउन। एनजीओ कर लिया ना वो।
एलईडी।
एनजीओ कर लिया था ना उसमें।
हाँ उसने किया।
क्या कह रही है?
मुंह गीला कर दो भाई।
मुंह गीला कराओ।
ये
कराओ।
पकड़ो जरा गन।
कम ऑन।
बढ़िया
बढ़िया है।
ठीक है, लाओ ओसीडी करा दो एलईडी में एक।
फर्स्ट क्लास है, लाइए ओसीटी लाइए।
एलईडी में ओसीटी करा था, लाओ ओसीटी कैथेटर।
1 मिनट, ओसीटी एलईडी की आपको
ये है ना, रुको रुको रुको, छुप गया है। हाँ मिल गया, छोड़ दो छोड़ 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 छोड़।
हम्म
हाँ पकड़े क्या एलईडी,
ठीक है सर, कंप्लीट करो।
बस ठीक है, उससे मालूम पड़ जाएगा एलएम ठीक है।
फिक्स।
हम्म
हम्म 1 मिनट देखने, रुक जाओ, रुक जाओ। ठीक है ना ये? हाँ लाओ, दो, इसको फिल करो। ओके फाइन, लाओ।
कर दिया पर्च। हाँ करते हैं।
हो गया, बताओ। हाँ हाँ
रुके, शूट हो गया।
एक्चुअली हम जल्दी शूट करते हैं, वो कुछ
हाँ
इंडिकेशन आता
रुकना
है क्या
होता है,
वहां पर
हाँ
शूट का?
रुकना होता है, रुकना होता है।
उसी में गड़बड़ होती है।
हाँ उसमें लिखा है ना 3 PM पे करना है,
अच्छा, 3 पे करना है।
हम लोग शुरू में दे देते हैं।
हाँ
तो
वो,
उससे वो जब तक वो होता तब तक मूव करता, तब तक फिर से आ जाता है। यार ये इधर उधर होता रहता है।
उनसे पूछो वहां अभी और आना है उनको या है? आना है, अच्छा।
ठीक है फाइन,
तो
वेलोसिटी
इसको वो
दिखाना है
दिखा
हमको।
दो, वो दिखा दो, ये सर्कमफ्लेक्स की तरफ भी कर देंगे।
दोनों करना है,
इसको इसको वो कर दो,
करते
मुझे
हैं।
दिखा दो जरा ये।
और कर दो, तो पहले कर लेते हैं।
हाँ निश्चल से कहीं पर वो लाल यहाँ जो है ऊपर।
ये छोड़िए, नहीं हमें इधर आना है, प्रॉक्सिमल दिखाइए, लेफ्ट मैन की तरफ आइए, आइए और आइए और आइए, आइए और पीछे और पीछे और पीछे।
और
हमें ये सेगमेंट देखिए क्या है,
चलाओ।
ये फ्लैप है,
नहीं वो जरा सा है, हैं
डिसेक्शन है।
माइन्यूट, उससे कुछ होता नहीं है। कितना
हाँ
है ये?
ठीक है,
हाँ
डिसेक्शन है।
नहीं, so this is how many degrees? This is just about 10 degrees.
हाँ तो वो ठीक है,
And how long it is? कितने फ्रेम में आ रहा है? चलाओ।
डिसेक्शन, हाँ लेंथ बताओ डिसेक्शन के।
यहाँ नहीं है। 2 3 4
ओ
5 6 7
आगे
7 फ्रेम्स। कितने मिलीमीटर हुआ? 3.5 mm and
मिलीमीटर,
about 15 degrees. So that is
मतलब
okay.
1 क्वाड्रेंट से ज्यादा होना चाहिए ना।
So that is that. Circumflex का दिखाओ, लाओ।
ना वो भी कर लेते हैं, जी जी। इसमें तुम्हारा कितना
जरा वो
डिग्री से ज्यादा
दिखाओ,
इंपॉर्टेंट मानते हैं डिसेक्शन?
एलईडी टू सर्कमफ्लेक्स, एलईडी टू लेफ्ट में आते हुए लाल बिंदी एक आधी आ रही है, वो क्या है? ये क्या, ये तो ठीक है। ये अच्छा, ये तो हवा में है ना। चलाओ, ये तो सर्कमफ्लेक्स पे आएगी ना, सर्कमफ्लेक्स के
ठीक है,
बाद। और दिखाओ,
अपोज,
वहां सब अटैच्ड है।
अपोज
नीचे एलईडी में दिखाओ,
डिजिटल।
यहाँ पर कुछ कम है क्या लूमन? ठीक है मेरे ख्याल से।
नहीं ठीक है,
कितना एरिया?
4.5।
हैं? I'm not too sure. बैठो।
देखते हैं अभी एनजीओ करके एक बार।
Thrombolysis, which I don't know, madam. Actually, people give wrong data, man.
Where we did the angioplasty, was it a post thrombolysis in some cases?
Madam, actually, the
Or
primary,
there was all palm?
no, primary PCI is only 16%. And definitely the total PCI, following PCI, following MI comes to nearly 30%. So the 14% is post PCI, post primary PCI, post thrombolysis.
Yeah, endo to balloon time was.
No, that much detail. Madam, this detail is itself is difficult to get.
So I think I would encourage everyone to actually give that data, so that
Data properly.
Yeah. Thank you very much, Dr. Pratap. Dr. Goel, we are back with you.
Yeah.
Yeah.
Okay, so I am doing the last run from the circumflex. Okay. So can we just finish this run and then I'll show you
to
what.
make it fast
I have completed the thing. I can show you. Can you show me the from where we left? From where we left?
एनजीओ
एनजीओ
जब छोड़ा था,
हाँ
हम एलईडी को स्टैंड करने वाले थे।
हाँ नीचे आओ. Okay, we did the LED stent. Start here. नहीं ऊपर. अरे यार. Start कर दो ना. Let us start. We'll run it through. Move. So that was the LED stent.
They are not listening to you.
Which I said. Are you? Am I audible?
Yes, very well.
This is the 328 stent which I had decided to leave proximal to the left main within the LED. So that is that stent, which is next angio, please. Next. And then the next one that I took was 4012. Actually, I might have taken 15, now this is the view. There was some dissection at the top of this
distal edge, can you show the distal edge of the...
Yeah, it is overlapping with the previous stent.
Okay.
Overlapping with the, I know that, but I can show that. That's it. Can you see that?
Yes,
it's overlapping. Yes. Next. So then we did that stent, and next we inflated that to about 12 atmospheres. Next.
So you put a stent from the mid part of the LMCA to the...
Yes.
So can you show the proximal edge of the LMCA?
Yes, so that is the proximal edge of the LMCA.
No dissection?
Well, I have done a OCT. It shows a dissection of about 15 degrees to 3.5 mm length. So I think that is okay. I can show you the OCT. Okay. After that, we did a kissing balloon. Move forward. I'll show you the OCT at the end.
What we have seen actually, Dr. Goel, in the last case, when Dr. Rafai did also, the proximal edge dissection was there. Here also there is a proximal edge dissection.
Yeah, so whatever it is.
So do you recommend in every patient of LMCA intervention, the stent should extend up to the ostium of the LMCA?
Not really the ostium, but this could have been 3 millimeter more proximal. I had decided, I had opened it, I had put it. It was okay, but probably a 15 millimeter instead of 12 would have been a shade better. I do agree on that. I will show you the, then we did a kissing balloon. Next. So kissing, usually what I do is cross it and then take a 1.5 balloon to create a track and then do the 2 balloons. So this was 3 and 3.5. And this is the picture after the kissing balloon. Angiographically, it looks pretty good.
Very good result angiographically. So
I don't
Will you do anything more issue. Now?
Then I did a OCT to the to the LED. You see the OCT, it is seen here. We can run it through all the way. Can you run it through and show that's the dissection part also, which is seen at the end, at the proximal end. Just run it through. Just run it through. Just run it through. Keep moving.
Can you do fast? Because
yeah. I think
Forward.
Just move forward to the proximal end of the stent.
Proximal edge.
Yeah, so that is the stent in the left main. Move. So this is where it starts. You see that little hole on the at 11 o'clock? Move forward. So that is it. Move forward. Move forward. 7 frames it finishes. So that is about 3.5 mm. It's a small thing. I don't think we did.
I think we can leave it.
Yes. So
So-
that's what I think. And I am in the circumflex to do the last circumflex OCT, and that will end the case, I think. So can you do the circumflex OCT? I'm already there.
Can,
Okay. Yeah.
Dr. Goel, actually, can you show the
Yeah.
last run and then we have to stop it there?
Yeah. I agree on that. Just
Shoot.
so that is the last run of the OCT. You can see the OCT picture because I have also not seen that. Show me the OCT picture by jaldi se.
Last run, finished. So distal to the circumflex stent, any problem is there? Number one. Number two.
No, yeah, you can see that. Let's run it through. So distal, there is no problem. Okay, that's the circumflex running. Go, keep moving, please.
Posterior only,
Keep moving.
posterior only to be seen.
Keep moving. And then maybe a little under a post there. Keep moving, but it's not red still. It is still white. Okay, keep moving. That's the proximal in the left main. Keep moving.
Thank you.
So the left main is also okay beyond that.
Thank you very much, Dr. Goel, for a wonderful disposition of an LMCS standing strategy and making us very good.
Thank
very
you.
much.
Thank you all. Okay.
Okay.
Right.